Okay guys, thanks again for coming in today. What I want to go through is just a quick, review of hyperkalemia, followed by a presentation of a patient that was attended by Amelia and myself on road. So having returned to the Northern Territory from down south, I saw maybe 2 hyperkalemic patients in 12 years. I think I've seen near on 27 in 3 months. In the Northern Territory, so which has been a great education opportunity and showed me the diversity of hyperkalemia, which we'll talk about today. So just a little bit on the pathology of potassium, and Andrew, this will be just a review for you, no doubt, with your extensive pathophysiological background. Yeah, that's right. So potassium, so as it says there, it's one of the most important cations or positively charged ions that's within the body. Functions as an electrolyte and helps regulate fluid balance in the body, obviously, and as we've spoken about previously, with the kidneys that becomes a bit of an issue. It is required for sending nerve signals throughout the body, and it also helps with contraction of both skeletal and cardiac muscle. It is the most prevalent cation within the cells themselves. As we said in the previous presentation, 95 to 98% of all potassium is sourced through dietary intake and stored in the muscles. The body tries to maintain a normal homeostatic range of 3.5 to 5.5 milliequivalents per litre. How this is managed is through the movement of sodium and potassium as the cells discharge and pass on energy, and this is done minute by minute and regulated by the sodium-potassium pump, which is important to think about when we consider how we manage these patients, in particular in the pre-hospital environment. Generally, most of the excess potassium in you and I is removed from the body by urine output. And so you can see how this then becomes quite an issue for patients who have chronic or acute kidney disease. An elimination is linked to sodium delivery also in the kidneys, and we spoke about the glomerular filtration system that is required, as well as the effects of aldosterone and adrenal corticosteroids. So that there is important too, because we talk about then the impacts of drugs like ACE inhibitors and antihypertensives and those type of medications, which also help regulate fluid balance, and that fluid balance then directly impacts the patient's blood pressure. So in hyperkalemia, it's most often seen in patients with acute kidney failure or chronic kidney disease. Several factors that increase their susceptibility includes a reduced GF rate, which we've spoken about today. Metabolic acidosis, so patients who are constantly, and this is where the diabetes comes into it, so patients become metabolically acidotic, and that impacts their patient's rate of retention of potassium. And then high dietary intake. And as we saw, it's not just bananas. Bananas obviously is the one that we most commonly think of, but any fruit-based potassium intake. Other risk factors include medications that interfere with the angiotensin-aldosterone system. Hyperkalemia causes a rapid reduction in the resting membrane potential of our cells. Increases extracellular potassium, reduces the ability of the myocardium to become excited, and increases depolarization timings, which we see in the ECG, and we'll talk a little bit later, so you get your QT prolongations and so forth. It also depresses pacemaking and conductive tissues, which is why we then see the bradycardias associated with high potassium. Progressively worsening hyperkalemia leads to suppression of impulses at the SA node, and that includes completely obliterating it and removal, which we'll show you in the case presentation that I have. And it also affects the speed in which transmissions are conducted down through the AV and Purkinje systems to the patient's ventricles. This results in bradycardia, conduction blocks, and ultimately in cardiac arrest. So what are the effects on the patient's ECG when they have high potassium? Now I'll start off by just saying that this is a guide only, and this is definitely patient specific. That you are going to see patients that are in the higher spectrum that will have no overt signs of their hyperkalemia in their ECG. Conversely, you'll see people who are only just hyperkalemic presenting with quite marked symptomology, especially in the ECG. So it's important to understand that these are generalist rates of hyperkalemia as associated with an ECG change. But, again, get here and find out about a patient that's sitting at ED with a K of 12 who's essentially asymptomatic. So you can't write fiction like this shit, all right? So with regards to the serum potassium, when you start getting above 5.5, we start to see some of the repolarization abnormalities and the T-wave peaking. Now, I remember when I did my paramedic course, and you'll say you've got a good memory because it was 30 years ago, but we talked about these big, tall, peaked T-waves. And we're often referring to the T-waves that we see associated with crush injury and hyperkalemia from cell destruction. That's not necessarily the case. So we do get the higher T-waves as referenced against the QRS in our hyperkalemic patients in the dialysis population, but don't be looking for these massive, spire-like T-waves. It's not necessarily what they're talking about when they're talking about hyperkalemic T-waves, especially in your dialysis patients. So you have a peaking of T-waves as referenced off of the QRS complex. As you get a little bit higher, at 6.5, you then start to get that paralysis of the atria and your SA node. P waves starting to widen and flatten themselves as a P wave, but also their duration starts to increase as those conduction rates start to slow down. You can see some first degree type AV blocks occurring or variable blocks, and so those that are astute at reading ECGs might pick a Mobitz or a Wenke back or something like that, but you'll only have minutes of it, as you'll see in the case example that we'll give. And then eventually your P waves will disappear. As they get closer to 7, you then start to get some more conduction abnormalities, especially within the ventricles. So that includes widening and bizarre looking. We start talking about that sine wave pattern. In your QRSs, you get complete AV dissociation. The P waves, if they're still there, will have no reference to the QRS. Sinus bradycardias through to very slow AFs, and then the classic sine wave pattern. As a general rule, in patients who are still hypersensitive to high potassium or high K, they have the potential above 9 to start looking at Torsades type pattern with their ECG, a VT or a VF. They may even proceed straight to a PEA, so pulseless electrical rhythm, which is often something that resembles a ventricular escape and or asystole. So as you can see, the effects of having high potassium in these instances can be quite catastrophic to our patients. So in this case, the patient called for an ambulance. It was early in the morning, about 2 a.m, and we were sent code 1 to a camp in town for a female, 47 years of age, acutely short of breath. Now that's not an unusual call in ALIS. And would often present with one of 3 potential common outcomes, I'll call them. One is pneumonia or respiratory tract infection. The second would be sepsis. And the third most common would be fluid overload and APO. So when we get to the patient, she looks distressed, looks unwell, and she's sitting on her mattress and looks washed out. She looks very fatigued, which is an important thing to remember because potassium, one of the things that it does when you have too much of it is it creates this sensation of fatigue in the muscles and so forth, and they have this generalized weakness. They don't want to move around, even though we need to sort of get them moving. She gave us a pretty good history at the time, and this poor lady was essentially, one of the things from the CART course last week that I learned about the Aboriginal people, and it's something that's sort of being drummed into me more and more that I have contact with them again in the territory is what they'll prioritise their own health over. So they will prioritise family, culture and country over their own health. And that's a really important thing to keep in the back of your mind. As healthcare providers, we will always promote health to them and try and sell them the things that they need to do to be healthy. And that's part of the education process, I guess, for the renal dialysis unit and selling this. But because it is such an insidious process, it's hard for them to draw a parallel to their health and the needs of their families and so forth. So in this case, this lady, and I'll say young lady because I'm 47, was down at Fink, and it wasn't for the desert race. She's not a big Honda fan or anything like that. She was down there to see her family. She was down there to connect with her country and to help with some ceremonial business. So she was away for a little while. She's got a history of ischemic heart disease, a history of hypertension, again type 2 diabetes mellitus as a result. She was Hep B positive and in stage 5 chronic kidney disease, so end stage. She has a fistula in her left arm, it was functioning. And this lady eventually develops a 3rd degree heart block, but not on us today. Her medications, and we spoke about this in the previous presentation, which is always good to have a link. It either proves we're both full of shit or we're both telling the truth. With this patient, she's on calcitrol, which is a vitamin D for calcium, required for calcium regulation. Salima, which is for blood phosphates, again attaches to the foods to control phosphate levels within your dialysis patient. Your anti-anemia agents, your antiplatelet agents, and antihypertensives on aspirin, and then on multivitamins, which is also important when you're sort of diet controlled and regulating fluid in your patients. So these medications you'll see up here are not unusual for our chronic kidney disease patients. This is the dialysis equivalent of the cardiac med shuffle, you know. So they're the type of meds that you would expect to see on the patient. So some history and examination. So she normally attends hemodialysis. She is hemodynamic, most certainly. 3 times a week. And she's missed the last 2 appointments. Now, it's interesting, when you and I talk about appointments, you would talk about Monday and Wednesday, for example, for this patient. What do you think 2 missed appointments meant for her? 2 weeks. So 2 weeks. So she's actually missed 6 dialysis. So she's been trucking along quite well for a little while. She awoke suddenly with acute shortness of breath, at rest, and had a moist, productive cough, which was not normal for her. She had a rest rate that was between 32 and 40, and if we tried to get her to sit up, move, do any minor movement whatsoever, her respiratory rate increased. She was not exercise tolerant at all. Despite that, remarkably, she had SATs of 99% on room air. She did have crackles mid-zones to bases. She was alert, but she was very anxious and distressed. She had impending doom. Reports fatigue, lethargy and muscle weakness. Her initial heart rate, she was quite bradycardic. So her heart rate was sort of hovering between 40 and 45, but her blood pressure was very high, 220 on 122. She denied any central chest pain or heaviness. And her 12-lead ECG revealed a developing 1st-degree AV block with wandering atrial pacemaker. Her QRSs were starting to widen and her T waves were becoming peaked. There was some QT prolongation, but not quite long enough yet to say she had QT prolongation syndrome. Shortly after the initial ECG was taken, and this was the amazing part of this case, was we actually got to watch her P waves disappear on the ECG whilst we were monitoring it. And I've caught a little bit of that today. She then went into what looked like a junctional bradycardia and then a widening QRS. Very few ectopics in her ECG. So the patient, our diagnosis was that she was acutely fluid overloaded, classified as APO as a result of that, and she was hyperkalemic. So, first strip. So this is from the monitor strip. So you can see we've got some flattening P waves there and some distortion in the P wave, and they're not all the same. And then, as the ECG went across, we started to see them disappearing. And another thing to note on this first ECG is the QRS morphology. Okay, so it's not quite widened. We're starting to get a little bit of prolongation there, but it's not a first degree AV block. And so this was done on the mattress in the bedroom, and the patient hadn't got up onto the stair chair as yet to be extricated to the house. Now, we were worried about hyperkalemia based on these two here when we initially saw it prior to doing the 12 lead, and then when we looked across there, and this is what I'm talking about, having thresholds for understanding what those T waves look like. They are quite tented T waves, but in relation to the peak of the QRS, they're about the same height. And so you go, oh, okay, well, yeah, there's a bit of hyperkalemia there, the bradycardic, so we've decided to start salbutamol, and we'll talk about the importance of salbutamol shortly. But I wasn't getting too excited about the calcium at this stage. That would change, because this was then the second ECG that was done once the patient was on the stretcher. Now, we're talking 15 minutes of time difference between the two ECGs. You'll note that in the pericardial leads, the T wave is still there and still quite peaked, but now it's melding into the QRS, and we're starting to get the widening and almost sine wave looking in lead 2. So patient gets calcium because we now want to stop this from happening. And I guess that's one of the reasons why we wanted to do this presentation today, was just to show this patient was probably special in a lot of regards in the way that she did progress fairly quickly with her condition, and we were fortunate enough as her carers to witness it and take some learnings from it. But this could be any patient that you go to in hyperkalemia, which is why I guess we should have a reasonable threshold for its management, especially given the amount of chronic kidney disease patients that we see in southern Northern Territory. Patient has this quite bradycardic rhythm. It's dropped down. It's still sitting around 30 to 40 at the moment, and it would be fair to say that both of us had an anal flutter of 2 to 1 when we saw this. So when they talk about the management of hyperkalemia, they talk about the 5 priorities of hyperkalemia. So first one is to protect the heart. Second is to shift the K into the cells. And then the third, fourth and fifth, remove K from the body, monitor the potassium and glucose, and then prevent recurrence. So 2 of those we can absolutely do pre-hospital. So we can provide medications that will stabilise the cardiac membranes, and then provide another medication that will help with the shift of potassium back into the cell from the extracellular environment. So what was our management? Basic care and a systematic assessment. So that was everything. That was sugars, it was temperature, 12-lead ECG, multiple sets of OBS. Tried to do some serial ECGs on our patients, which bore fruit in this case because we got to see the changes and the reason why you do serial ECGs in these patients. Patient was given oxygen via the nebulizer and then given 10 milligrams as a stat dose of salbutamol. Now, salbutamol works by activating the ATP production, which then helps activate the sodium-potassium pump. Ideally, we want to take the potassium from the extracellular environment, return it to the intracellular environment. It doesn't just reduce the amount of K dissolved in the blood, but also restores the function of the cell. Obviously, you want to have a cell that's more positive internally than externally, so your anions can travel down the outside and transmit nerve energy or contract depending on what the cell type is. We then established IV access, and the patient was given 1 gram or 10 mils of calcium gluconate 10%. Now, calcium gluconate doesn't have any role in removing potassium. It's important to note that. It is just there as a membrane stabiliser. Patient's then placed on a stair chair, extricated to a stretcher just out the front, put in the back of the car, reassessed, and then we travel to the hospital with a notification. So we're fairly fortunate on this case that she did okay, and we'll talk about how she transitioned. But some other things that you might want to consider. Now, our current protocol and many protocols still have sodium bicarbonate within there. It was interesting because I remember from early teachings, the thought was that by mopping up hydrogen using bicarbonate, you would change the pressure gradient of your cations, and therefore, there would be this affinity to draw potassium back into the cell and sodium out of the cell. Turns out that was all fiction, probably like the use of adrenaline in cardiac arrest. However, we still continue to have it in a guideline, like adrenaline in cardiac arrest. So there is still a place for it though, and that is, so when you look at the literature, most of the literature doesn't support its use in hyperkalemia at all anymore, and very limited sort of narrow therapeutic window for its use in the sort of hospital environment would be those patients that are extremely acidotic, to manage the acidosis. It's not to manage the hyperkalemia. So that's its narrow therapeutic use. However, still indicated in cardiac arrest. So if you have a patient who you suspect is down in cardiac arrest secondary to hyperkalemia, they still get sodium bicarbonate as per the current guideline. IV fluid if they're poorly perfused. Now, a lot of these patients that are fluid overloaded are going to not require any additional provision to their fluid requirements to maintain a blood pressure. However, if in isolation this person was a dietary overdose of potassium and not necessarily fluid overloaded, the impacts on their cardiovascular system may see them become hypotensive, either secondary to their bradycardia or other vessel derangements due to the shifting of different cations and anions. So you can use IV fluid in these patients. As with all these patients, again, I would limit it to 250 ml aliquots of fluid to maintain a blood pressure. Atropine for the bradycardia, a lot of people go, well, why don't we sort of aggressively manage the bradycardia? Well, there's no point in giving a drug that activates or blocks the activation, because the body's always in a process of trying to downward regulate itself. And so the parasympathetic nervous system is trying to slow everything down. And so the idea behind giving atropine is to block that parasympathetic nervous innervation, and therefore the body would naturally try and speed up. And the heart would. If there was nothing else going wrong with me or any other person, I gave you atropine to block the parasympathetic nervous system, you would bang away at 100 beats a minute, no worries whatsoever, because we're just blocking that downward regulation. These patients, though, they're not downward regulated. All right, their problem is that they have too much potassium, which is affecting their ability to conduct. And so, therefore, atropine probably is not going to be effective unless you treat everything else first. You've got to manage the hyperkalemia first and stabilise the cardiac membranes. Adrenaline infusion. Interesting in the literature, so if you gave some fluid, they were still hypotensive, and you're thinking we need to now go to an inotropic type of support for this patient. Well, this is actually has some evidence for its use, and so if you're worried about fluid overloading them, it is a good option. And so we can start an adrenaline infusion on these patients. The secondary benefit of adrenaline is similar to the beta-2 that we're getting from salbutamol, is that it assists in the sodium potassium pump's regulation of intracellular K. So don't exclude it. And then finally, can we pace these people? Well, you can. But I would only pace them after you've tried the adrenaline infusion, which is in most standing protocols now for pacing patients, is that we do try and get them sped up and their heart rate and blood pressure, so cardiac output, so stroke volume and their heart rate up with adrenaline. Because again, without any management of Ventolin, calcium, and adrenaline prior to pacing these patients, you're probably going to find that their capture is going to be poor. And so you're going to need higher and higher energy levels from your monitor to achieve pacing outcomes in these patients. And so things to consider from our perspective is one dose of Ventolin going to be enough? The literature across the board supports upwards of 20 milligrams. And you're going to see a lot of side effects on your patients. With just 10 milligrams, this lady had the salbutamol shakes. And so you need to expect that. in your patient, and just be aware that at 20 milligrams, they are probably going to be sitting there looking almost like they're having a conscious seizure, just from the salbutamol. Yeah, sure. Yeah, yeah, sure. So, how was your short career as an ICP? I guess would be the question. And it's funny, you say that, but it's a real risk in all patient care, isn't it? That we just try and manage what we think the symptoms are, and you can grab a hold of the outer aspect of the vortex and get sucked in very, very quickly, experimenting on our patients. So clearly no midazolam for your salbutamol shakes. I won't name and shame you on the video. Okay, so the other is considering a second dose of calcium. Now, a little controversial. The UK model for management of hyperkalemia is quite an extensive document. Talks about people's fear in giving too much calcium and then they becoming hypercalcemic, and then the side effects that you might get with that. But they believe it's quite safe as a general rule to give 2 grams of calcium if these patients are extremely unstable. So if you do start to see multiple ectopics and stuff like that. But as a rule, 1 gram is generally enough for these patients. So on this occasion, our patient improved. Her shortness of breath improved slightly, more the sensation than anything else. We didn't shift any fluid, and given that she was already a little bit overloaded, we probably didn't improve her APO as such. Remembering that salbutamol in the subacute APO patient will be diagnostic, because you'll go from having a tight chest to having a chest full of fluid, and this probably helped some fluid stay in her chest. However, we weren't treating a fluid overload, we were treating the thing that was going to kill her, which is the cardiac arrhythmia. Her ECG rate and rhythm improved over the 30 minutes post-arrival at the hospital. So after I finished doing the case sheet, which was well over 30 minutes, and going back, and they said, oh no, her heart rate's picked up, it was sitting around 60. The first K that was taken was 6.9. So they estimate, given the Ventolin, given their ongoing Ventolin treatment in the hospital, that her K was probably closer to 8 prior to our management starting. So as you can see, she's still in the danger zone here at 6.9, but that's the reason why we saw the progression of her ECG as quickly as we did, because she was starting to get to the lethal side of potassium. But then how slow it comes down. At 2 hours, she was still at 6.3. And by this stage, she started glucose infusion and insulin infusion to help shift some of that K. And as was stated in the previous presentation, they were working hard to get her blood pressure down to allow her to be in a fit state to undergo hemodialysis. Unfortunately for this patient, however, this event has probably created an amount of damage that her heart wasn't able to sustain, because 5 days later she represented not in fluid overload, but with chest pain, and was found to be in a complete heart block. As a result of that complete heart block, she was flown to Adelaide to have pacemaker placed. So, you know, the seriousness of this disease and especially of hyperkalemia is this type of impact. Not only is chronic kidney disease a life-limiting condition, but then if you don't manage yourself, as we found out with fistula placement and stuff like that, you can dramatically reduce that patient's life expectancy because of any danger or injury that things like high potassium or being hyperglycemic can cause. So that's it for my presentation on hyperkalemia. Tried to keep it short, sharp and to the point. Is there any questions?
Does anybody have any questions?
I guess the most important thing, especially from a paramedic perspective, is the early recognition and request for assistance is always there. You know, it's the last line on all of our guidelines, call for backup. But these patients you need to start treating early. So the salbutamol is what's going to reduce their potassium levels in the interim and try and buy you some time you can get to hospital so they can reduce their overall potassium levels.
I like that you use this scenario, because I've definitely found over the last couple of years that I'll get to a patient and think, what is going to kill you first? As in, you know, is if someone's really distressed in that APO, but then they've got ECG changes, things like that. So it's been good to just think about navigating that and calling the backup early.
Yep. Yeah, absolutely.
Even if it's just for extrication, not necessarily if you don't have ICP on, but at
Yep.
least to help get as much done as you can.
Yeah, exactly. And I guess that comes back down to having a systematic approach to your patient. I guess the temptation's there to continue to do things that we have always done, and that might be with regards to cancelling back up early. Some people might get this patient and go, they're fluid overloaded.
Yeah.
They've missed 2 dialysis, not 2 weeks, but missed 2 dialysis sessions. We'll just give them some oxygen, we'll get them on the stretcher, we'll take them to hospital, and may or may not have even done an ECG on this patient in that interim period. Can you imagine how catastrophic 15 minutes of time may have been for this patient? So yeah, it's one of those things that, you know, we should be doing a holistic assessment of our patient, and actually doing what you know, we've been employed to do, and that is practice to the extent of our clinical knowledge and abilities. And so there is a lot that paramedics can do for these patients.
Yeah.
You know, there's if the patient in isolation and we weren't concerned about smashing her blood pressure, I guess that's another concern. This patient was an APO patient, but we didn't manage the patient's APO traditionally by giving drugs like GTN. And why would that be? What was
Her heart rate was 40.
The heart rate was 40, that's right. So it's automatically contraindicated,
Yeah.
isn't it? Yeah. And so that contraindication comes about because they might have a high blood pressure, but they're quite pre and afterload dependent at the moment. The cardiac output is part of their equation of heart rate is taken out of it. So if we then compromise that preload and afterload by giving a drug like GTN, any drop that they may have in their blood pressure could be catastrophic. And remembering this, part of this is almost like a head injury heart rate, that the patient's extremely hypertensive, so the body's trying to reduce that cardiac output by reducing the heart rate. But also then the effects of the derangement of their electrolytes is also affecting that blood pressure. So they're you know, I could have almost called this presentation not a routine patient either. You know, because we see so much of it here, it can become quite easy to be a little bit complacent with our
100%.
With our CKD patients, and I think this was certainly a wake-up call for me, and I'm glad I got it earlier in my time in Alice Springs and not later. And I can see now why Sue in clinical really carried on about managing these patients appropriately in the pre-hospital realm, because the effects of not doing it are catastrophic.
I think it really highlights the appropriateness of treating these patients all the same. So regardless of what time of the shift it is, how tired you are, how many missed dialysis patients you've just had in a row, at 3 a.m, every single patient who's missed dialysis goes on your stretcher. Every patient gets serial ECGs. Every patient who is missed dialysis gets treated the same.
Yeah, absolutely.
Set your standard so that you can't get caught off guard.
Yeah.
Hey?
Exactly.
That's why you create your system and you have your standards, so
Yep.
that you can make sure that everybody gets the best care possible, no matter how tired you are.
No, exactly. And we do operate in a space of high workload and high fatigue. And the good thing about having systematic, reproducible clinical approaches is that it becomes second nature.
Yep.
It's like breathing on a job. You train for war, but hope for peace, and that's what this is a little bit about. You know, if you do that stuff automatically on every single patient that you attend, then the likelihood of you missing something or making a mistake. One other thing that I'll add in, and before I finish off, is when you're operating in small teams, and this has been born of the grad cert in aeromedicine as well as the CART course, is closed loop communication. So making sure that you're speaking with your partner. I remember 30 years ago when I started in ambulance, and we were ambulance officers back then, used to assume the role of driver and patient care officer, and never the twain shall meet. That is not the case now. There are numerous professionals on the case, whether or not that professional is a PTO, if they're a paramedic or an ICP. It's important that everyone has input into that patient's care, and that if it is 3 in the morning, that you might see something that the ICP doesn't, or the PTS officer might see something and recognise it from previous patients. Speak up. Make sure everyone's aware of it, and there will be a, does anyone else have anything that they want to add in on the care of this patient? Because your voice is important. Human factors stuff in pre-hospital care is becoming more and more focused on, because we want to reduce the impacts of making errors, especially now as a registered profession. And so making sure that as a team you're communicating well, that everyone understands if you're getting drugs out, drugs are cross-checked, and then verbally cross-checked. Dose is a question. You know, it wouldn't be the first time that an adrenaline amp has been handed to someone in the place of morphine or something like that. So it's important that you just slow down, suck in a little bit of air, take the time, feed the information back.
Go. In regards to this case, just as an example, so you treated for the hyperkalemia, would you then have gone on to the APO, like considering CPAP or anything?
No, it wasn't necessary for 2 reasons. One, CPAP we generally use for work of breathing control, and the second is to help the patient maintain their oxygen saturation. So once the patient was placed on oxygen, supplemental oxygen because of the nebulizer, their SAT sat on 100. So they were quite well oxygen saturated. If anything, you know, once the treatment was finished, we probably would have just wound that back a little bit so she wasn't so oxygen saturated, because we don't want to create any more complications of constriction of vessels and so forth like that. But yeah, if she was struggling to maintain a reasonable saturation and her work of breathing required some assistance, then absolutely.
But her distress and her impending doom was not because of hypoxic nature.
No, that was anxiety related.
And more like, my heart is going 40 beats per minute. Yep.
Yep.
Have you received any negativity from the receiving clinicians at hospital around giving calcium? Because
so it's something I've expected.
Yeah.
Because there is concern about calcium salt deposits within the kidneys. But I think, as was explained today, this is an emergent technique required to stabilise cardiac membrane. So I don't think that would ever weigh into my judgment to treat. Secondly, the kidneys aren't producing any urine anymore and have zero function. On this occasion, we were received extremely well. During handover, they confirmed that we had actually given this patient calcium because they were going to give it if we hadn't. So I think that's the important thing, that when you recognise that the patient needs that level of care, you should be treating them based on your knowledge of the pharmacology and what the patient needs, not necessarily on the reception you might receive at the receiving hospital, which, you know, is very important. That's right, yeah. All care, no responsibility. All right, thank you very much, guys.